Good evening, everybody. It's 7:30, so in the interest of time, we do want to make a start. So welcome to this evening's Opioid Treatment in General Practice webinar, Assessing for Dependency and Understanding Treatment Options. We're joined tonight by our presenters, Dr. Hester Wilson and Dr. Linda Mann. So before we get started, I'd just like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. Okay, and I'll just give you a bit of background on our presenters this evening. So we have Dr. Hester Wilson. Hester's an addiction medicine specialist as well as chair of the RACGP Addiction Medicine Network. She has a master's degree in mental health and 25 years experience working in the primary healthcare setting. Hester is also a staff specialist in addiction at Sydney's Langton Centre Drug and Alcohol Clinic and has facilitated training for doctors and other healthcare workers since 2001. Dr. Linda Mann is a fellow of the RACGP and member of the RACGP Antenatal and Postnatal Care Network. Linda has both local and international medical experience, especially in genetics and women's health. She is a GP representative on various national and local government committees and is an experienced medical educator. So in saying that, I will now hand over to Linda, who will take you through the learning outcomes for this evening.
The learning objectives for this webinar are as follows. By the end of this online QI and CPD activity, you should be able to explain how to ask, screen and assess your patients who are using opioids, including over-the-counter codeine for opioid dependence, and understand options for treatment. You should be able to assess which patients are appropriate for opioid agonist treatment, also called OAT, in the community setting, based on complexity, need, and risk. You should be able to discuss the process involved in starting a patient on buprenorphine naloxone and understanding when takeaway doses might be appropriate. You should be able to explain the legal framework for prescribing S8s and list where to find additional clinical support and information to improve patient care.
Fantastic. We'll hand over to Hester now to start the presentation for this evening. Thanks, Hester.
Thanks, Sammy. Hi, everyone. It's so fantastic. We have a huge amount of you online. It's really, really brilliant. We have a lot to get through in the hour. And as Linda said, we do have specific outcomes that we're looking at, but even getting through those is going to be a bit of a task in the hour. So I will try and get through things quickly. Linda, keep me on track. Look, just wanted to do a little bit of background around opioid prescribing in Australia. And this is a pretty busy slide, but the really important things that I wanted you to look at was, first of all, look at the rise in codeine. Look at the rise in tramadol. Look at the rise in oxycodone on the left there. Look at what's happened with fentanyl and with buprenorphine. And that the buprenorphine that this one is talking about is Norspan patches, not buprenorphine specifically for the treatment of opioid dependence. We'll be talking about that as well. Hydromorphone. So what we're seeing is increased use of these medications. And there is no doubt that opioids are essential medicines. They're on the WHO's list of essential medicines, and they are brilliant for the management of acute care. Their role in the management of end-of-life care is very important as well. Their role in the management of chronic non-malignant pain is much more contested, and I would argue that we really need to think hard about how we're treating that and how we assist our patients. We will talk more about the problems with opioids in the using in chronic non-malignant pain, but what we have clearly seen is with the increased supply, we are seeing increased harm. And here we have, now this is old data, but what we're seeing is between 2000 and 2012 increasing mortality. So we look at heroin. Heroin is a dangerous opioid. It's very quick onset. There's a high risk of overdose. But what we're seeing is increasing overdoses, increasing deaths from overdose from pharmaceutical opioids. And this includes the ones that we prescribe to our patients, not just the ones that are kind of obtained from mates or bought on the street. These are our patients that we are prescribing for. So, chronic pain and opioid use. Now, one of the things that's tricky for us is that with chronic non-malignant pain, we want to treat people's pain. It's a really significant thing that really affects people's lives, and there's been enthusiastic uptake of opioids to manage this. The problem is that for some people, they actually not only become dependent, but actually have addiction or aberrant behaviours. And certainly, the rates of addiction and that's not just dependent, but these aberrant behaviours between 8 and 12%, depends on the populations that you're looking at, it may well be higher. The point cohort, which is a recent Australian study, 1 in 4 met the criteria for addiction. 1 in 5 met a lifetime criteria from the ICD-10 for a opioid use disorder. And one of the things that I really want you to take home from this is not the drug using, heroin using patient, though it can be, it's our patients as well. And these people that have these issues are our patients in general practice, and they're not injecting, they're taking it orally. And all of our patients who are on opioids are at risk of harm. This is both a dose dependent, as the dose goes up, the risk goes up, and is also affected by the other comorbidities that people have. And so just coming to one of the hot topics at the moment is the over-the-counter issues and over-the-counter codeine. And I think one of the things that's really interesting is we don't know quite what's going to happen with the change of codeine from being over-the-counter to prescription only. I don't want to go into a great deal of detail around the reasons for the change. However, I do think it is a good idea because of the risks and the harms that are happening to people in our community from over-the-counter codeine use. When I look at the use of over-the-counter codeine, really it's a spectrum of presentations that we are seeing and will continue to see, and maybe we'll have a larger group of people after the change. We'll have a group of people who go to their pharmacy and the pharmacist says, look, sorry, we can't give you your Nurofen Plus anymore, but there are these other options. And they'll go, oh, well, I used it for my headaches occasionally, but this will do me as well, thanks very much. There will be the people at the other end who quite clearly have become dependent and have what this SUD is, a substance use disorder. So they have the dependence, withdrawal intolerance, and also the aberrant behaviours. And certainly when we look back at some of the studies, we're looking at 1 in 5 people actually being part of this criteria. So I'll come to that in a moment, but just looking at the spectrum, at one end you've got the occasional user who will quite happily move to another OTC medication. You've got the people at the other end who quite clearly are dependent. Then you've got this group in the middle. And they are a group who will need some assessment and some thought around where they fit. Now, it may be that you decide, sorry?
You may remember I mentioned a patient of mine who fits into that criterion.
Yep.
This was a patient who went to his chemist routinely for paracetamol and codeine 15 milligrams. The chemist sent him to me for Panadol Forte once the chemist could no longer provide the lower dose stuff. When I assessed him, he turned out to have 3 pains. One was postherpetic neuralgia, one was sciatica, and one was mechanical low back pain. And he was much happier on Lyrica and an NSAID.
Yeah. So I think it is that thing of really doing that assessment and sorting out, what is the appropriate treatment? And you may decide that your prescription codeine is the way to go, but you'll want to do a really good assessment for that. And I have to put in a bit of a plug around codeine. It's a prodrug. It's being metabolized to morphine, and it's variable, so it's a tricky drug to work with. And there are some people that get no effect, and some people that get a lot of morphine are at risk of overdose. So it's not one of my favorites, I have to say. But so moving on, there's the issue for people using OTCs is that they didn't know where to go. They've been using them as over the counter, and they may not always be coming to us and saying, I'm using this. Ideally, hopefully what we'll see is that they'll go to the pharmacy will say, look, got to see a GP, and then we're in a position to actually intervene and ask the questions, do a good assessment and work it out. Coming to Richard. Now, Richard is a guy who's been using Nurofen Plus for 3 years for an infected wisdom tooth. He stopped once the wisdom tooth was removed, but actually started using it as a crutch to help relax his nerves. He was having a really tough time at work. And by the time he was seen, he was taking 45 tablets a day of Nurofen over the last 12 months. So round about, 500, 600 milligrams of codeine, roughly equivalent to 50, 60 milligrams of morphine, taking into account that it depends how well he metabolized or didn't metabolize the morphine. He tried to go cold turkey, but had sweating, shaking, poor concentration, nausea and vomiting, and says, I cannot go through that again. That was just really tricky. So my question for you guys is, and I want you to type it in there, what else do you want to know? So people saying, what's his renal function? Absolutely. Does he use any other alcohol and other drugs? Other comorbidities? Background history, alcohol, mood disorder, recreational drugs, pain, history of alcohol, other substances, allergies, psych history, other comorbidities, full medical history, gastric symptoms. Beautiful, beautiful. Okay, all right, can we move on to the next slide? So a little bit more about Richard. He's a bartender, also studying IT at uni. 4 drinks a day, 1 day a week. Yeah, so 4 standard drinks 1 day a week. No history of injecting other drugs, no cannabis or methamphetamine use. He's a smoker. Other social history is his father had alcohol dependence, and this is a man who's had no mental health history in the past. Other than at the moment, he's incredibly stressed with work and with the bullying that's going on. So what do? Type me some answers. Listen. Assess mental health. Address mental health. Negotiate tapering. Counselling. Mental health care plan. Regular follow-up, I guess. Liver function. Counselling. Psych support. Psychiatrist. Gradually taper off drug and alcohol referral. Assess mental health. Reassure. Renal. Refer. Plan for reduction. Offer other options. Assess readiness to change. Advise that drugs are not a solution. Refer to pain assessment, psych review. Smoking cessation has to come off. Apply for an authority to prescribe. On that point, I'm going to move on. Next slide, please. Okay, so what I wanted now is to just really quickly look at this third group that I spoke about before, the people that have the dependence, tolerance, withdrawal, and the aberrant behaviours, and really looking at, so we've got DSM-4, which many of us grew up with, DSM-5 and ICD-10. They're going to bring out ICD-11 soon, but we're not quite sure what that's going to look like. One of the really important things to look at is the dependence versus use disorder. So dependency is about the tolerance and the withdrawal, and we know from our patient that we've got here that he's having withdrawal symptoms, and he says, I can't go through those again. But the other thing is looking at this, the criteria, and this is looking at using larger amounts for longer than intended, persistent desire, unsuccessful attempts to cut down, cravings, great deal of time spent using and recovering. Now, this young man was racing around to different pharmacies, buying his Nurofen Plus from a number of different pharmacies, reducing his other activities, continuing use despite the fact that it actually was not helping him. He was having interpersonal problems as well, continued use despite recurrent physical and psychological issues, recurrent use resulting in failure to perform major roles, recurrent use despite legal problems, recurrent use in hazardous situations, and the tolerance and withdrawal. So when you're looking at your patients and thinking, where do they fit in this spectrum? Where do you think this guy fits in that spectrum? So we're looking at, yeah, can change easily to something else, clearly needs to actually have treatment for his dependence and aberrant behaviour, his substance use disorder, or is somewhere in the middle. Use disorder, substance use disorder, dependence, use disorder, dependence, both, use disorder. Okay, all right, so I am, just to let you know that the RSUGP will send you out that page. I think it's a really nice summary of the different ways that you can look at it. I think, Sammy, you're planning to send that out at the end. Moving on to the next page. So the next thing, and it's a really important thing, is how you actually talk about this. And I think that you may well be right that this young man is in that third group, and therefore we need to look at what are the most effective options to help him manage. How we speak about this to people is really important. There are reasons why our patients may not tell us about this stuff, because they don't realise it's important, they don't think it's part of our role, or, as was the case with this patient, feels incredibly shameful. I feel just so shameful that I am running around to all these pharmacies and this is out of control and I'm trying to hide it from my family and friends. And so it's really important the way that we approach it, that the language that we use, the support that we give, looking at the potential benefits of the drug use and the negative aspects. You know, so and just coming back once again, what do we know about opioids? And this is important information to share with our patients. Really, there's not much evidence that it works that well in chronic non-malignant pain in the vast majority of patients. Higher doses and longer term use, you have diminishing returns. You really, it's fewer benefits the longer you use it and the higher the dose. You know, and 50 milligrams oral morphine equivalents is associated with increased risk, and over 100 is even higher. So getting that dose down, and I would also say getting people off long-term use and moving towards intermittent or other options is actually where we should be heading. Next page. And for me, this may sound cruel, but in a way, I'm really not interested in their pain. I know they're in pain. I'm much more interested in your function. I'm much more interested in what your life looks like. So we do have the 4 or the 5 A's of pain, of chronic pain. And really for me, the activities of daily living. I want to know, how are they going? How are they going when they get up in the morning? Are they able to get to work? Are they able to do some exercise? Are they able to hug their kids? Are they doing some physical activity? How are they sleeping? How much is their pain and this treatment that they're using affecting their lives? Analgesia, it's important to have that conversation about pain because that's the patient's experience, but it's, as I say there, it's modest but meaningful. Adverse effects, what are the side effects? Is there constipation? You know, is there nausea? Are there vision changes? You know, what are actually happening? Are there problems with their gut and with their kidneys? Also, I would put this in the side effects. I'm always really fascinated that somehow dependence and substance use disorder get put aside from adverse effects. This is an adverse effect of this medication. So this is a side effect. Treat it as a side effect that can happen to anyone. It's not a moral conversation about someone who is using. It's actually about this medication and the way it's affecting them. The aberrant drug taking, the addiction related things, so things like racing around to different chemists, using more than they intended, coming in early, you know, for extra scripts and things being out of control. The other thing is managing their mood. So certainly it's quite clear with Richard that he was using this medication to manage his stress and his anxiety about work. Now, many of you may have seen these and some of you may love them and some of you may hate them. I really like them. I'll just quickly go through it. The PEG pain screening tool is 3 questions, so it's quick and easy, and it gives you a sense of what's happening with their pain, their enjoyment of life, and their general activity. The other one on the right here is the brief pain inventory. Now, I've not put down there's 2 pages, so there's actually 4 questions about pain and there's 7 questions about pain interference. These can be really useful because they're validated tools, so they're a way that you can quickly get to what their scores are, and you can look at scores over time. So, you know, you either love these outcome measures and these tools. They're a bit like the DAS-21 in terms of, you know, the way you use them. You know, have a look at them. A copy of them is going to be sent out to you, but you can also just Google them and find them online. And if they're useful for you, go for it. I really like the BPI, the Brief Pain Inventory, but I happen to know, Linda, that you hate them. Is that right?
Well, I don't hate it. I do find the 3 question stuff really helpful. And in fact, I've made an autofill in my software so that when I forget what the questions are next week, because something else has come in, I'll remember how to use them. That's what I've found. But I don't have the same collection of patients as you have. So, you know, horses to call.
Well, I think the autofills are really great because once again, and it's just a quick and easy to remind you, you know, and that's one of the things for us as GPs. There are so many things we've got to remember. I have a lot of autofills and they're really useful. Just wanted to highlight the Pain Management Network. So this is part of this, the Agency for Clinical Innovation. Really great website, lots of information for patients, for young people, for people with specific spinal cord injury pain, but also for us as health professionals. Lots of stuff around assessment, the management of chronic pain, lots of resources, and a quick steps. So you can kind of go through what are your red flags, where do you need to go. Really encourage you to go and have a look at it. There's also some great videos of the patient story of patients talking about their experience. Moving on to the next page. Okay. Once again, I think for me, the idea that opioids are going to cure and wholly manage what is chronic non-malignant pain, which is a complex experience, is naive. And in terms of looking at people's chronic pain, really looking at, I need to understand this person, their biopsychosocialness of them. And the other really important thing is putting in those other active strategies to help them manage their pain and retrain the brain. There's lots of information on the ACI website about that. The non-pharmaceutical, the non-pharmacological strategies, and universal precautions. So think about this for everyone. Time-limited opioid use, intermittent opioid use to get people moving again. And if you're thinking about weaning, some people can do it easily, but for many people it needs to be done quite slowly. There's some really good information on the ACO website about deprescribing and weaning. Next slide. Once again, some of the stuff on here, it's a basic approach. You need to work collaboratively in your general practice, case conference your difficult cases, one prescriber, one pharmacy, involve your pharmacist, consider staged supply or supervised dosing. So pharmacies can, you can say, look, I want this person to get 2 days dose at a time or a week's dose at a time, or I want this person to come in and be dosed in front of the pharmacy, so we're actually observing them taking their dose. You know, no drugs of addiction will provide on a first appointment, can actually help in terms of the walk-ins who are looking to find drugs. But at the other end of it is also understanding that this is complex and people with problematic opioid use, they need help. You don't need to do it all. Do ask for help. We'll have some more information at the end about where you can go. Contact the Prescription Shoppers Information Service. Look, there are limitations on it, but it's as good as it gets at the moment. And I have to say, I have a patient at the moment who has come up on the pharmaceutical shopping line, and in the last 3 months, he's seen 113 prescribers and gotten 114 scripts for endone. So it was very useful for me to ring and find out that information. The role of urine drug screening, it has a role. Do check with your local pathology what tests they actually do, because they don't always check for all of the prescribed opioids unless you check that they do. The other thing is check cost. So before you actually do that. And I wouldn't say that that's the be all and end all, but it can be a useful adjunct for finding out information and supporting your plan and keeping the patient safe. The other thing is your patient-centered care plan or contract. And there's heaps of information on the ACI website, but also the Hunter Integrative Pain Service has some really good stuff as well. Anything you wanted to say about that, Linda?
I think the interaction between you and the pharmacist is good. I didn't understand until we're preparing for this that in fact all pharmacists have the ability to undertake this. It's not a special characteristic of special pharmacies. So if your own pharmacist is a bit wary, it might be worth having a chat and saying, we could do this together. Let's just start with 1 or 2 people and see how we manage. My personal experience is that when I have visited pharmacists, particularly for in a different circumstance, but for palliative care patients, for example, the pharmacists are over the moon that I've come to the chemist shop to actually have a chat with them because they regard them as colleagues. It's great.
Yeah, absolutely. We will talk a little bit more about the role of supervised dosing. Can we go on to the next slide? Okay, so coming back to our Richard. So he's taking 45 tablets of Nurofen Plus per day for the last 12 months, and he has clear withdrawal symptoms. And you guys, vast majority of you said, yeah, he's in that dependent substance use disorder category. Some people said maybe he's in the 2nd and 3rd group, maybe a little bit different. It's difficult to know. And certainly some of you, when we said, what do you do? You've said, I'm going to refer. Brilliant. Now that is certainly an option. The issue with referring is you've got to know where to refer, and you've got to ensure that there are services to actually do that. The other thing is your opioid agonist treatment. Methadone and buprenorphine plus naloxone are both treatments that are, if we are saying this man has an opioid use disorder, dependency and an opioid use disorder, there is no doubt that methadone and buprenorphine plus naloxone, also known by its trade name Suboxone, are really fabulous, strongly evidence-based treatments that work. And we will be coming to that in more detail. We're going to be focusing on Suboxone rather than methadone, but I'll talk a little bit about methadone as well. The role of naltrexone, which is a mu antagonist or an opioid antagonist, it's possible it does have a role. There really isn't a great deal of research that's been done around this. There are some people that are doing naltrexone implants, but that is clearly experimental. It may be that it's useful in a group of people who have totally withdrawn from their opioids. You cannot use this when people are on opioids, otherwise it will make them withdraw. But it may be that naltrexone can help some people to prevent relapse, but it's a very small group. Naloxone, I put that up there to remind myself, just to remind you guys, naloxone is something to think about with patients, all of our patients that are on opioids. If they are at risk of overdose, and how do we assess if they're at risk of overdose? You can look at their comorbidities and the dose that they're on. Have they ever had an overdose before? Also talking to family members. Think about prescribing some naloxone. Now, shortly, we hope that we will get an intranasal form of naloxone, but this is using this Narcan or naloxone to actually treat overdose. And don't underestimate how often overdose happens. We can see the deaths that are happening there. They're happening in our patients. And I've certainly seen it in the coroner's cases that I've been a witness for, where general practice patients who are non-injectors overdose and die, and quite often they're in a house with family or friends and people don't realise, they don't have the skills, they don't know what to do, and the person dies. Moving on.
Hester, on a related subject, one of the questions is, why is not weaning codeine an option? And I was wondering if you'd make a comment about working out how much a person's actually taking and what would happen if you just stopped that. And this is relevant to Richard.
Yeah, so the issue, first of all, with Nurofen Plus, you could absolutely, and that may be what Richard wants to do, is to slowly cut down the dose, and that is certainly an option. One of the issues, one of the problems with the Nurofen Plus is, first of all, taking massive doses of Nurofen. Yeah, you don't want this man to be continuing on these massive doses. This is a real risk to him. The other thing is that codeine is short acting. So as you try and cut down, even if you did it with your codeine on its own, it's a short-acting medicine, so people have to take it very often, and it's hard to actually work out what the best way is to do. So we wouldn't generally cut it down using the Nurofen Plus, particularly given that he's taking such a high dose. If it was a lower dose, if it was within the range that you felt, look, it's not a particularly high dose of Nurofen, you certainly could try, and for some people that will work. You need to see them regularly, you need to have a clear plan, you need to be helping them to work through it just as much. Okay, so opiate agonist treatment. Opiate may not be appropriate for all persons, as we've said. But it is appropriate where you know that people are dependent, that they've tried to manage it. Yeah, so he's tried stopping it, it hasn't worked, and he's gone through terrible withdrawal. If they're at risk of overdose or relapse, and if they're willing to consider it. You know, people may say, no way, I don't want to do that. In which case you're trying your other options to help them manage their withdrawals. It could even be things like, we're going to try and manage your withdrawal symptoms with things like Maxolon and Lomotil to manage their symptoms. My experience with that is they don't work particularly well, but that is an option. The thing that you can do with thinking about Suboxone is that it is brilliant for alleviating the symptoms and signs of physical withdrawal, and helps to get people's lives back on track, to stabilize, and allows time for them to get things back on track. And I can't underestimate how fabulous that is for many, many people. So Richard, like many of my patients who've gone into problems with over-the-counter medicines and racing around pharmacies, they will start on Suboxone and they will say to me within days, oh my God, Hester, I feel so much better. I feel so much less anxious. I'm sleeping better. I'm not racing to pharmacies. Why didn't I start on this earlier? Moving on. So I wanted to talk a little bit about buprenorphine naloxone. It's an interesting medication. This is a combination of buprenorphine naloxone, and Suboxone is what its trade name, and it's the only one in Australia. So just to make things simple, I will use the trade name. It's sublingual. You put it under the tongue or in your buccal mucosa. and it is a partial agonist. And this is a really interesting part of this drug. It makes it really safe. It makes it much safer if people take too much, that they don't overdose, because it has this ceiling effect. The other thing is that if you are withdrawing, if you have opioid withdrawal, it will act like an opioid, an agonist, and will relieve the withdrawal. If, however, you have another opioid in your system, it will act like naloxone and send people into a nasty, very full-on withdrawal. So it's really important to be aware of that. If you're looking at starting somebody on Suboxone, you want them to be in withdrawal before they start. Codeine is short-acting, so you can start them on pretty quickly, and we'll talk about how you do that. It's up to a maximum dose of 32 milligrams, and that is a huge dose of buprenorphine. When you're looking at the ones that you might have had experience with Norspan patch is in the micrograms, whereas this is in the milligrams. If you're looking at trying to sort out, is somebody in withdrawal and how much withdrawal are they in? And I would say you want to start on a low dose and commence when the patient's in moderate withdrawal. There is a clinical opioid withdrawal scale. There's a copy of that that's being sent out to you guys that can just really help you to know, is this actually withdrawal? So it can give you a score and tells you when it's mild or moderate. Lower overdose risk, as I said. Yep.
Hester, one of the questions was exactly about that, about the risks of overuse, abuse, etc., of this drug.
Yep. All opioids have risk, but this one is much less risky because it has a ceiling effect, and it's from about 32 milligrams, that it just doesn't cause the respiratory depression that other pure agonists cause, that it's much less risky. If, however, you take it with a whole heap of alcohol and other sedating drugs, benzodiazepines, sedating antipsychotics, you can still overdose on this, but it is much safer than the pure agonists. Okay. It is true that some people will end up misusing this medication, and that is an issue. However, it's much less of an issue than it is in terms of, say, for example, the oxycodone misuse. And having the naloxone in there means that people much less likely to inject it, because what happens if you inject it is the naloxone becomes active. So if you take it under the tongue, naloxone does very little. But if you inject it, you actually get withdrawals. So people tend not to inject it. It is safer. I wanted to point out this really important change that's in italics at the bottom there. There are new guidelines that we hope are coming out very, very soon. It is now under the guidelines in New South Wales, all of us can actually commence up to 20 people at any one time. We can have 20 people on our books that we are commencing on buprenorphine, naloxone, Suboxone without doing additional training. And that is because this is such a safe drug. The only issue that I would warn you about is just be clear that you don't want somebody that's got opioids and is, has lots of opioids in their system. If you put the Suboxone in at that point, they will withdraw. It's not going to kill them, but it's really, really uncomfortable. So wait until they are in withdrawal. But it's a very safe medication, and I'd be encouraging you guys to think about this. Maybe the first time you start commencing, have a chat to your local drug and alcohol team, or your local clinic to look at getting some support around doing this, because it's new, but it's a very safe drug and it's really effective. And what we know in this group of patients is that it's actually even more effective than it is with the injecting heroin user who has a much more entrenched lifestyle around their drug use. Moving on to the next page. Very quickly, this is opioid withdrawal symptoms. Now, many of these signs are not specific, but taken together, particularly the tearing, the goosebumps, the runny nose, the yawning, the dilatation of the pupils, irritability, tachycardia, nausea, vomiting, all those things taken together, can give a really clear picture. I'm interested, Linda, with your patient that came in, was he having any withdrawal symptoms?
It was actually a bit difficult to tell because he actually has got a long-standing skin condition, which always makes him a bit restless and itchy, and he has piloerection as a function of that. He had no nausea, he didn't have any withdrawal headache, and he and I decided that he wasn't dependent, and that's why he was willing to think about other drugs.
Yeah, Yeah, I'm certainly thinking of one of my patients who was seen by another doctor and was complaining of nausea and vomiting and diarrhea, mostly diarrhea, and had a whole heap of gastro investigations. But it turned out she didn't tell my colleague, and my colleague didn't ask about her 60 codeine, her 60 Nurofen plus a day. But in actual fact, she was actually presenting with opioid withdrawal.
You
so
know,
do think about it.
I've always thought that nighttime diarrhea is secret doctor business. Anyone who gets up to go to the toilet to have diarrhea is either overdosing with alcohol or codeine or has an actual proper gastro disease. It's a real secret little.
Yeah, it's something to think about.
Just while I've got you, there is a question about the use of this drug in the ACT. Do you know whether or not there's any?
Oh gosh,
yeah.
I'm not entirely sure because that's out of New South Wales. It's another world. I do understand there are opioid agonist programs there. I'm not sure if you can actually commence Suboxone. What I would suggest if you're an ACT GP, my apologies, I should have thought of this because of course our ECGP is New South Wales ACT, have a talk to the ACT Drug and Alcohol Service and check out if you can actually commence people on Suboxone. I can also check with my colleagues there, and maybe Sammy, you can send out an email to let people know.
Yeah, no problem.
Next slide. Yeah, so once again, be aware of precipitating acute withdrawal. Your patient will not like it, you will not like it. So that you need them to be in active withdrawal. Start them on a low dose and then build the dose up. Moving on. There was a Cochrane review in 2016. In people that have prescribed opioid dependence, it is quite clear that they do well on opiate agonist treatment and do better than heroin users. The other thing is CBT to support them to manage their anxiety, their pain. You know, we know the psychological therapies are really effective with chronic non-malignant pain. So do think about that as well. Moving on. So, okay, this once again is some of the evidence around how effective buprenorphine and buprenorphine naloxone is for pain and opioid dependence. You start the treatment the same as for any opioid. And what you find with people is that their pain is reduced. They get up to pretty good doses. You know, these are the doses that I'm using with my heroin dependent patients. They have greater improvements in their quality of life. And both methadone and buprenorphine naloxone are effective analgesics, as effective as opioids can be in chronic non-malignant pain. Some really good information on the NDARC website if you want to go to that, and that's certainly in the list of our resources that we'll give you at the end. Moving on. So we wanted now just to pull back and just have a little look at, first of all, this is New South Wales Health, so my apologies to my SCT colleagues, but this is the New South Wales Health website, which looks at pharmaceutical services and particularly in terms of your legal responsibilities. So medical practitioners there. Clicking on. So here we have the things that you need to do. So once again, prescribing an S8 opioid for pain management. Click on that. If we are going to prescribe in New South Wales for a drug-dependent person, and we've already said that Richard is drug-dependent, or for a non-drug-dependent person for longer than 2 months who has any of the following, we need to get an authority. And you can see that particular authority down the bottom there. It's an authority to prescribe an S8 drug of addiction, and this is what you need to do in New South Wales. So you can apply for an authority to prescribe a drug of addiction. This is an authority to prescribe methadone or buprenorphine. Now, for you, if you're non-accredited, you can apply for an authority to commence buprenorphine, or you can apply for an authority to continue a person that's already stable in either methadone or buprenorphine. So this is the form that you need to fill in. So there are 2 forms. The first one is an authority to prescribe an S8, and it's those particular drugs that we saw on that previous screen. And on this one, this is an application to apply for methadone or buprenorphine. And as I said before, you can now actually commence buprenorphine, and we'll spend a bit of time looking at how you actually do that. I just saw a question, people saying, how long does it take? In terms of an authority to prescribe under this, with this form, a day. In terms of the S8 form, a week or so, but you can move it quicker. Give them a call. The PSU guys are really friendly. The pharmacists who work there love talking to us. They know their stuff. They're really, really good. Going back. Okay, so I would really encourage you to have a look here. There's a lot of information here. We've got the chronic pain management, lots of stuff that you can look at on this site. Also, there's the stuff around the S8 benzodiazepines. The other thing I wanted to point out, and if you can go to the pharmaceutical benefits page, because this is sometimes a bit confusing, there's also a PBS authority. So the PBS authority is a federal thing and it is different to the New South Wales authority. If you're going to prescribe, you probably need to apply for both, depending on the situation. So don't get the two confused. The other thing is don't ever give a private script. You know, really, really want to do it through the PBS. Guys, have a look at Hunter Integrated Pain Service because they have a whole heap of information there as well. So I hope I've made that clear because it's really important in terms of legally prescribing. Here we go. There's some beautiful stuff there. You know, it's really important that you're doing this legally. You know, so that if you have someone that is drug dependent and you're going to continue them on codeine or oxycodone or fentanyl, you need to apply. If you've got someone that's on those list of medications that are on the website and they're not drug dependent in your opinion, but they've been on it for longer than 2 months, you need to apply. You also need to think about your PBS authority. My apologies to my ACT colleagues. I will check out what the story is there and Sammy can email you guys. So moving on. Are there any questions there, Linda? Yeah.
Yes, there's a number of questions about pregnancy. So a number of GPs have said, can I prescribe this in pregnancy? To which my response is, GPs shouldn't be doing this on their own. It needs to be done under the vision and friendly help of specialists, even in remote Australia. So another person said, well, they do have a friendly specialist, but the GP sees the patient in between the specialist attendances.
Yeah.
Give us a thumbnail sketch on that issue.
Yeah, absolutely. Look, first up, Linda, you're absolutely right. If you've got someone who's pregnant and is opioid dependent, get the specialists involved. You really, it's tricky because you don't want that woman withdrawing. So you really get the advice. We do use buprenorphine in pregnancy. We don't use buprenorphine naloxone. Buprenorphine has been clearly shown to be safe in pregnancy, and in fact, babies have less of the neonatal abstinence syndrome than they do with methadone, but we don't use the naloxone because of the risk of it causing withdrawal symptoms in the fetus, which damage the fetus. So get help with that one. You're absolutely right. Thank you. Okay, so coming to the changes, and I've highlighted this already. So all GPs will be authorised, all of us, don't have to do any special training, to prescribe for up to 30 patients any one time. You can commence up to 20 people on buprenorphine naloxone combination, not buprenorphine on its own. It needs to be the buprenorphine naloxone combination, and you can take over the care of up to 10 patients who are already stable on methadone. And you want that to be people who are really stable and doing well. And once again, ask for help if you're not sure. Don't do this on your own if you're not sure. So coming back to Richard. So he's on his 45 tablets. He's got features of substance use disorder, and after conversation, he's decided that he wants to start on the buprenorphine naloxone combination. So how do you do it? So day one, he's seen at 10 a.m. Now, the really important thing about this is that you're not going to be doing this in your rooms. You need to actually look at, depending on where you work, doing it with your local pharmacy, doing it with your local private clinic, or doing it with your local public clinic. But the way that you do it is you get the person to stop the night before. Because codeine is quite short acting, he stopped at 9:30 p.m. last night, and it's now 12 hours later, and he's in mild restlessness with mild myalgia, nasal stuffiness, bit of mild anxiety. His clinical opioid withdrawal scale is 4, so he's not in withdrawal enough now. Starting Suboxone at this stage may well send him into precipitated withdrawal. So what we did was say, hey, look, hang around or go for a bit of a walk, have a cup of tea, have some lunch, you know, look after yourself if you're not too nauseous. Come on back at 2 p.m. Now he's more symptomatic, diarrhea, flushed, sweating, agitated, a COWS of 10. And we started him, first of all, on a test dose of 2 milligrams. When he had no reaction at all and actually felt a little bit better, another 2. And with the option of going up to 8 milligrams on the first day. So the pharmacy then, we made a call and he had a total of 8 milligrams. So he was actually started in the pharmacy in this setting, but it could just as easily have been started in a clinic if you have access to those where you work. So on the first day, he had 8 milligrams. One of the really important things about this is you're looking to titrate to symptoms, and you want to do it quite quickly. You want to induce people into the treatment quite quickly, so you don't need to worry about conversion. If, however, he was only taking 8 to 10 codeine, I'd start on a much lower dose. And in that case, we'd be looking at, because for you guys at the moment, what the government is saying is it has to be Suboxone, that you would need to involve, unfortunately, if you didn't want to, but a good idea if you do, your local drug and alcohol team to prescribe buprenorphine mono. And you'd be looking at the 0.4, 0.8, 1.2 doses. Moving on to the next page. Day 3. So we reviewed him again. So he was uncomfortable the first night, had 8 milligrams on the second day, and then a further 4 milligrams in the evening, and was feeling much better by the second night. He was kind of surprised that he didn't get any of the euphoria. And we looked at moving that dose up and took it up to 16 milligrams and said, let's try and settle on that dose. But he can take it down if he gets too sedated, and the pharmacy can call me. So I'm in contact with the pharmacist, looking at how he's going, and it's really about symptom control. The other important thing to say to people is it's not all going to be perfect by day 3. It takes a couple of weeks for it to totally settle, so hang in there, take some time off work, look after yourself, get some support. Moving on to the next page. 3 months after starting, he's still on 16 milligrams of Suboxone. He's working well and has actually gotten involved in some hairdressing styling work, and is starting to think about decreasing. So this is in the realm of people with substance use disorder. At 3 months starting to think about cutting down is pretty short, but this is a man who is working, who is doing pretty well and is looking at a slight decrease. 6 months, he's going well on 14 milligrams, really didn't notice that dose decrease. He's been thinking about seeing a psychologist, and he's thinking about how that has affected him. So at 6 months, he's on 14 milligrams. Now, when you're looking at this, he's being dosed probably in a pharmacy, maybe in a clinic, but much more likely to be in a pharmacy. And it's really important to have ongoing conversations with that pharmacist. The other thing is looking at, does he go to the pharmacy every day for observed dosing, or can he get some takeaways? And we'll talk a little bit more about that in a minute. Moving on to the next slide. 1 year after starting, he's down to 10 milligrams, and he really didn't feel that dose decrease. Now he's on fortnightly dispensing. So he's going into the pharmacy and he's picking up 2 weeks worth of medicines. When he first started, he would have actually been on daily dosing while he got that dose titrated, and probably moving towards some takeaways. But now, a year after starting, he's down on fortnightly takeaways. He's seen a psychologist and he's starting to decrease to work towards completing treatment. Moving forward. 2 years after starting, he's on 4 milligrams and he's decreased to 2 milligrams. And what we're looking at is further reductions and looking at maybe second or third daily dosing. Some people do find just stopping on the 2 milligrams. Some people need to do that a little bit more slowly. But he's also got better skills to manage his emotional space. 2.5 years after starting, he's now stopped treatment and is doing really well. So for him, there was this real sense of, why did I wait this long to get on treatment? This has been brilliant. I've put some work into managing my emotional life and my psychological health, and now I'm ready to move on from this. Linda, any questions? It's a lot to get through, and we've only got a little bit of time left, but yeah. I wanted to just make sure I hadn't missed any important questions.
Can I just go back to the issue of the paperwork, which the clinical stuff is interesting and we can all get that quick. The paperwork drives us all nuts.
Yep.
I'll quote a question.
Yep.
To get this straight, if you have a chronic pain patient who is on long-term OxyContin, you need to apply for an authority from New South Wales Health as well as a PBS authority. I've been told I didn't need to.
It depends if they're drug dependent or not. So what I would suggest is go back and look at the website and look at which of the drugs you need to apply for a New South Wales authority for. There's actually a list there on the website. If you want to, we can go back to that now. Have a quick look. Sammy, can you bring up that website?
More questions.
There's more questions?
So the next question is about distinction between methadone and Suboxone. Along the lines
Yep.
of methadone is something you seem to use for a very long time, Suboxone not quite so much.
It depends on the patient. And so the bottom line is both methadone and buprenorphine are fantastic for helping people with their opioid use disorder. We do have an issue with both of these medications that they are a replacement. They're still opioids. They're not perfect and they have side effects like opioids do. And cutting down takes time. The group of people that tend to be on methadone tend to be people that are more complex, have more psychological and physical health issues, have a whole heap of stuff in their history, their social history, trauma in their background. And so for them, getting to the point where they stop their methadone is quite often quite an extended period of time. And there will be some of my patients who will and are going into nursing homes still on both, either buprenorphine or methadone, because they actually have a more severe story with the illness, whereas others it'll be much shorter. The thing with the Suboxone is that it's really useful in this group because it's very long acting, and so the cut down is a little bit easier quite often. And the other thing is that methadone is a bit sedating, so it gives people that nice warm fuzzy feeling. So if you're someone that loves your opioids and loves being a little bit sedated, buprenorphine can feel like you're really raw. It doesn't cover you up in your nice blanket of sedation. And so it's great for people that are working because you can still think. It's great for people that want to use their brains. I had one of my patients who was an artist who'd started on methadone, and he loved that sedated feeling, but he knew that it was interfering with his ability to do his art, and moved across to Suboxone and got really creative and got working again, which was really brilliant.
Now, there are a number of questions that look at using other kinds of S8 drugs instead of Suboxone to wind people down.
Yep.
Using Tarjan, using oxycodone.
Yep.
Do you have any comments about that?
The issue here is that you could do that. This man is drug dependent, so you would need to apply for an authority. The first thing that PSU will say to you is, why don't you start them on Suboxone? It's really long acting, it's really safe. We can monitor it, you can get it monitored in pharmacy. You need to think about what's the most appropriate thing for your patient. And it may well be that you decide, because this person has been on oxycodone for a long time, that we'll just slowly cut it down. And once again, I would encourage you to go to the ACI or the HIPS website to have a look at their issues, their way that they talk about deep prescribing. You can certainly do that. I have to say with Tarjan, it's a bit of a trickiness that somehow that's safer. It's not any safer. It's a very strong opioid. It does have some naloxone mixed in. That's to manage constipation. You just got to think about what is actually going to be the most effective thing. And we know with Suboxone and methadone that they do really work with people with substance use disorder, opioid use disorder.
And my last question is, could you just make a comment about the overseas experience after codeine has been de-prescribed, put onto prescription only?
So most countries have now made codeine prescription only. As far as I know, the sky hasn't fallen. There are lots of other options that people can use to manage their acute pain. And that's, that's all I can say. The sky hasn't fallen. Codeine is not a great medication because it is so variable. It's a prodrug and it doesn't particularly work very well in many people.
Thanks.
Okay, so we've got 3 minutes. So in summary, ask your patients about their over-the-counter use and prescribed opioid use. Assess people's chronic non-malignant pain using the 5 A's, the PEG and the brief pain inventory. Give them support and information around the use and the risks. And for us as prescribers, carefully consider the risks and benefits before prescribing, because we're responsible for that prescribing. And if it is not safe, you don't have to prescribe. The other thing is that the opioid agonist treatment is a very well evidence-based treatment. It's safe and it's effective. We need to be thinking about this more, guys, and the guidelines are changing so that we actually can access it. If you're not sure, ask for help. the PSU, the website that we put up there, as I said, the pharmacists are great. They're really happy to help. Your local drug and alcohol teams, get that help. Don't try and do it on your own. Talk to your colleagues. You will have colleagues that have done more of this. Get support around it because it actually is a really great treatment that is available, and we need to use it on people that need it. Where to ask for help. Don't forget DASIS. DASIS, I think sometimes, the Drug and Alcohol Specialist Advisory Service, is the best kept secret. It is available for patients in the community to ring, but also for doctors to ring. And when you ring up, you will get a really quite knowledgeable intake person who will take the information, and then you get a call back from a drug and alcohol specialist, and usually pretty quickly. They're usually pretty good. There's a rural number there for us that are outside Sydney. The other thing is the Pharmaceutical Services Unit. They have a duty officer 9 to 5. That must say DASIS is 24/7. Whereas the pharmaceutical unit is 9 to 5 weekdays, and they're really helpful. Your LHD, talk to your local drug and alcohol services. There's a lot changing in terms of local drug and alcohol services where we're wanting to step up and support GPs more. Talk to your colleagues. If you've got issues around legality, MDU, your Avant, MIPS, whoever you're with, they have a lot of information around this. Join the Gypsy in Addiction group through the RACGP, of which I happen to be the chair. So that's the GPs with a special interest in addiction. Come and join us. Health pathways. More and more health pathways are being developed, and we're involved in putting together an opioid pathway at the moment to really, start looking at what's available in your local area. And the New South Wales Clinical Guidelines for Methadone and Buprenorphine Treatment, the new guidelines are coming and will be with us soon, and there will be some information up on the RACGP website, and there'll be an attempt by New South Wales Health to get that information out because this is a big change, and it's an important change, and it's a timely change given the changes to codeine. Next page. Some resources. I understand, Sammy, you're going to send those out so that everybody has access to those.
Absolutely.
And I think we've kind of come to the end. Questions? We've got all of no minutes. Yeah, so look, this presentation was put together over a period of time with many of my colleagues, many of whom are GPs, Dr. Susie Nielsen, who's a pharmacist and working at NDARC, Dr. Lucy Harvey-Dodds, who is has a GP background in the UK and is also an addiction specialist. So my thanks to those wonderful people for helping me put this together. Once again, guys, think about it, talk to your patients, be kind to yourself, be kind to them, ask for help when you need it. Help is available.
And Hester and Linda, I just wanted to thank both of you very much for joining us tonight. I hope everybody online has found it really helpful. I would also like to add that the RACGP upscheduling codeine page is now live, so you can jump on there to have a look at details and information surrounding that. There's also a contact on there from the RACGP that you can get in touch with if you have any questions you want answered. On that note, that does bring us to the end of this evening's session. I'd also like to add that to ensure you receive your QI and CPD points, you will need to complete the evaluation. There'll be an email that goes out in about an hour's time that will have a link to that. So again, thank you all so much for joining us tonight. I hope you found this helpful.